Welcome to The Explainer. Today, we're tackling something that sounds simple but is actually a huge diagnostic puzzle: leg pain.
All right, so let's get right into it. Why is this such a puzzle? Well, leg pain is super common, right? But here's the thing. The symptoms can look almost identical, whether the problem is in your blood vessels, your nerves, or even your muscles and bones. And that overlap, that's what makes it a real headache for doctors trying to figure out what's actually going on.
And you've got to understand, the stakes here are incredibly high. We're not talking about a minor inconvenience. If a doctor misses, say, critical limb ischemia, that's a severe artery disease, it could literally lead to amputation. Or if they delay treating something like complex regional pain syndrome, that could mean a lifetime of just awful, debilitating pain. So yeah, getting the diagnosis right isn't just important, it's absolutely crucial.
So how do clinicians even begin to untangle this mess? You might think they'd start with a fancy high-tech scanner, right? Nope. It actually starts with something much simpler: a conversation. It all comes down to some good old-fashioned clinical detective work.
And this quote right here, it really gets to the heart of what good medicine is all about. Before any test, before any scan, the single most powerful diagnostic tool is your story, what doctors call the patient history. The whole idea is that just by listening, really listening, they can often figure out the root cause, the etiology of the whole problem.
So they'll ask questions just like these. Think of it like they're building a profile of your pain. When does it hurt? Is it only when you exercise and then it stops the second you rest? Or does it happen just from standing up straight? And what does it feel like? A deep ache or more like a sharp electric shock? Every single answer is a vital clue that helps them start crossing suspects off the list.
This initial conversation and exam is also crucial for spotting what are called red flags. And these are exactly what they sound like: warning signs that something is seriously wrong and needs immediate attention. We're talking about things like severe pain combined with a fever, or one leg suddenly becoming cold and pale. When a red flag pops up, it's an all-hands-on-deck situation that bypasses the normal diagnostic process.
Okay, so once those first clues are on the table, the detective work moves to the next phase: building a list of the usual suspects. And for leg pain, the potential culprits almost always fall into one of three main categories: vascular, meaning your blood vessels; neurological, your nerves; or musculoskeletal, your muscles and bones.
And this is where seeing the pattern is everything. For example, let's compare two types of pain. On one hand, you have vascular claudication. That's pain from a blocked artery. It's like a traffic jam for your blood flow. It predictably starts when you exercise and stops almost immediately when you rest. But then you have neurogenic claudication. That's from a pinched nerve in your back. That pain often feels better when you bend forward, like leaning over a shopping cart. That's because that position actually creates a little more space for the nerve. Two very different patterns.
Now check this out, because it's pretty fascinating. If we zoom in on just athletes with exercise-induced leg pain, you see it's almost never a simple case. The most common cause, sure, is what we all call shin splints. But look, a full third of cases are something called chronic exertional compartment syndrome, which is a dangerous swelling in the muscle. And another quarter are actual stress fractures. The scariest part is, they can all feel pretty similar at first. It just goes to show you how vital it is to get that precise diagnosis.
This table really, it's like the ultimate detective's cheat sheet. It lays out the classic signature for each of the three main culprits. So if a doctor feels for a pulse and it's weak, or the skin is cool to the touch, they're thinking vascular. But if you're describing a sharp pain that shoots down your leg and your reflexes are a bit off, that's a huge clue for a neurological issue. And if it's just a nagging ache in one specific spot that only hurts with certain movements, well, the case is probably musculoskeletal.
All right, so once the story and the physical exam point to a prime suspect, then the diagnostic tools come out. But, and this is so important, their job isn't to randomly find the problem. Their job is to confirm what the doctor already suspects. And honestly, this is such a fundamental rule of good medicine. The tests are there to prove the theory, not to come up with it. The history and the exam, they create the hypothesis. The technology is just there to provide the proof.
So let's walk through a classic vascular case. We're talking about peripheral artery disease, or PAD for short. This is exactly that blood flow traffic jam we mentioned earlier. Plaque builds up in the arteries, the pipes get narrowed, and your muscles start cramping up whenever you ask them to work. So, the first test for this is usually something called the ankle brachial index, or ABI, and it's really clever and simple. All it does is compare the blood pressure in your ankle to the blood pressure in your arm. If the pressure down in your ankle is a lot lower, that's a dead giveaway there's a blockage somewhere in between. A ratio below 0.9, that pretty much confirms it's PAD. And you can see how the diagnostic path is super logical, right? It goes from simple to complex. You start with that quick ABI screening. If that rings an alarm bell, the next step is a Doppler ultrasound, which uses sound waves to literally watch the blood flowing. And then, for really serious cases where surgery might be on the table, they'll do an angiogram. Think of that like a super high-def GPS map of your arteries, showing exactly where every single blockage is.
Okay, let's switch gears to a classic neurological suspect, radiculopathy. You probably know it by its more common name, sciatica. And the key thing to remember here is that the problem isn't actually in your leg. The problem is in your lower back, where a nerve is getting pinched and it's just sending those screaming pain signals all the way down your leg.
So the biggest clue here is that the pain and any numbness or tingling follows a very specific path down the leg. It traces the route of a single nerve, an area called a dermatome. It's like the pain is drawing a map of the problem right on your skin. Once a doctor sees that very distinct pattern, they'll usually order an MRI of the spine to confirm exactly where that nerve is being pinched.
And finally, let's touch on one of the trickiest puzzles in all of pain medicine, complex regional pain syndrome, or CRPS. This is a truly baffling condition where the nervous system just goes haywire. It often starts after a really minor injury, but the body's reaction is to create this intense, continuous, burning pain that is completely out of proportion to what happened.
And what makes CRPS so incredibly hard to diagnose is that there's no test for it. You can't see it on an X-ray or an MRI. The diagnosis is pure clinical detective work, using a specific checklist called the Budapest criteria. A doctor literally has to check the boxes. They have to find symptoms that the patient reports and signs they can see with their own eyes across all these different categories, from sensory stuff like extreme sensitivity to touch, all the way to visible changes in skin color or temperature. It's a true puzzle that has to be assembled piece by piece.
So, we've walked through these different culprits and diagnostic paths. What's the big takeaway here? What's the ultimate lesson when it comes to solving the puzzle of leg pain? Well, it comes down to this. A great diagnosis isn't about fixating on a single symptom. It's about pattern recognition. It's about being a great detective, piecing together all the little clues from the story, from the physical exam, and from the right tests, until a clear picture emerges, a picture that points to one single cause.
And that really leaves us with a final question to chew on. We live in this age of AI and mind-blowing medical imaging. So is the future of diagnosis just about getting more and more data? Or does the real power, the true art of medicine, still lie in that simple human act of asking the right questions and then taking the time to truly listen to the answers? Thanks for joining us for this explainer.